Okay, so we are on page 116 for chapter 9, medications that affect coagulation. I know that there seems to be a lot of PowerPoint slides in this presentation. This is it's not too lengthy of a chapter, it's fairly short, but it is chock full of information that you do need to understand, and so that's why this is such a lengthy PowerPoint, but overall it shouldn't be too bad. Okay, so here are some of the key terms that we're going to be talking about throughout this chapter. But you do need to know that coagulants and anticoagulants serve two different purposes. And hemostatic agents enhance or accelerate blood clotting at a surgical site. And thrombolytics dissolve existing blood clots. Okay, so starting on page 116 at the top, blood naturally contains both coagulants, which promote clotting, and anticoagulants, which inhibit clotting. And so then further down in the blue, topical hemostatics are coagulants used on areas of capillary bleeding as an adjunct to natural hemostasis, and when natural coagulation factors are absent or insufficient, systemic coagulants are used to restore or enhance the coagulation process. Okay, all right, so anticoagulants are dominant. They keep blood in liquid form. That changes, however, when a blood vessel sustains damage. So then the body's coagulation mechanism starts forming clots to prevent excessive blood loss. Okay, so anytime there's an injury, that's when the clotting factor starts. Okay, so in that second paragraph, halfway down, a little bit further up, it says heparin is one such systemic anticoagulant. Okay, you'll hear a lot about heparin coming up. Further down in the blue, most other systemic anticoagulants are administered in the medical setting to prevent conditions such as deep vein thrombosis or DVT, or pulmonary embolism, which we have discussed, which is PE, which can be postoperative complications. Okay, so such natural coagulation is effective when the damage is minor, like the damage of a paper cut to your finger. And it's effective on venules, arterioles, and capillaries. Okay. Um, okay, the next paragraph. When a blood clot or thrombus forms within an intact blood vessel, a mechanism in the blood acts to dissolve the clot naturally. If the natural anticoagulation process is inadequate, thrombolytics may be administered to speed clot breakdown. Thrombolytics are agents used to help to speed the breakdown of existing blood clots as seen in conditions such as DVT, PE, coronary artery thrombosis, and myocardial infarction or MI. And then make sure that you know that yellow box, that make it simple, that's just for your benefit. It's the medical terminology between coagulation, anticoagulation, hemostasis, etc. Okay. So the body's natural anticoagulants serve some very specific, very important functions. Okay, so here it is, the physiology of clot formation. These are the stages. So stage 1, thromboplastin, also known as prothrombin activator, is formed. So we've had the injury, we've gotten a paper cut or something, we're actively bleeding outside of our skin. This is the first thing that's going to happen. We're going to form our thromboplastin. Okay, and figure 9.1 on page 117 shows that blood coagulation pathway. Okay, all right, so the body's coagulation mechanism prevents blood loss resulting from trauma or damage to small blood vessels. So this process is actually a cascade of events that occurs in three basic stages. So again, the first one is the thromboplastin forms. Stage 2, thromboplastin converts prothrombin, known as factor 2, into thrombin. And then stage 3, thrombin converts fibrinogen, also known as factor 1, to fibrin. Okay. Um, yes, and so fibrin is a mesh of protein threads, which is a net that traps blood cells to form a clot. Okay, so stage 1 involves two different mechanisms for the formation of thromboplastin, the extrinsic pathway and intrinsic pathway. Okay, so again, the two mechanisms or pathways. So this is the first stage of blood clotting. So both pathways, the extrinsic and intrinsic listed here, both form thromboplastin, but the intrinsic pathway is much more complicated. So continuing on, these two, so in this paragraph on 117 at the bottom left, these two meet at a specific point in the process called the common pathway. The extrinsic pathway is initiated by factors outside the blood. It is triggered by a clotting factor released from damaged tissue, like tissue thromboplastin or factor 3. The extrinsic pathway is a very rapid process that produces a clot in seconds. Okay. And let's see. Yes. All right. So at the top of 117, top right, at the very, very top, it talks about the Stewart-Prower factor. That is factor 10, and I need you to write that next to where it says Stewart-Prower factor. That is factor X or factor 10, okay? Okay, then it talks about the intrinsic pathway that is initiated by substances contained in the blood. This pathway is more complex and takes several minutes. When a blood vessel is damaged, the Hageman factor, which is factor 12, is activated. Factor 12 then activates plasma thromboplastin antecedent, which is PTA factor 11, which activates plasma thromboplastin component PTC factor 9. Lots of factors here. So again, the extrinsic pathway can produce a clot in seconds. It starts with factors outside the blood released from damaged tissue. After that, a number of blood coagulation factors play roles. Okay, and then the intrinsic pathway is another option in stage 1. It is initiated by substances inside the blood, is more complex, and takes several minutes as opposed to just seconds to produce a clot. So like the extrinsic pathway, however, it involves the blood coagulation factors shown here. Some are the same as those in the extrinsic pathway. Okay. Yes. Yes. Okay. So, in that second paragraph on 117, the clotting cascade requires calcium at all stages, so calcium enables many of the steps. Vitamin K also plays a vital role in coagulation. So, for example, it is required to synthesize prothrombin, which is factor 2, proconvertin, which is factor 7, PTC, which is factor 9, and the Stewart-Prower factor, which again we talked about, is factor 10. Okay, so stage 1 of blood clotting is essentially thromboplastin formation. And again, there are the two pathways, intrinsic and extrinsic. So a lot of these slides are redundant. I'm just trying to show you that there are two pathways in stage 1, and that's just making that thromboplastin. It just depends on if there was an injury or if something's happening in the blood. Okay, so in stage 2, the thromboplastin from stage 1 converts prothrombin to thrombin. All right, now in figure 9.2, that's an image of a fibrin net trapping red blood cells. And so in stage 3 of blood clotting, thrombin fibrinogen to fibrin creates a clotting net. The process of clotting is not as simple as this, though. It requires the right substances in the right amounts at the right times. Whenever one of these things is lacking, the cascade falls apart. Okay, and we just read about this. The two substances, calcium and vitamin K, both play vital roles in coagulation. Okay, so the next paragraph it says occasionally clotting may take place within an unbroken blood vessel. This abnormal clotting is called thrombosis. If it forms in an artery, such a clot, which is called a thrombus as a clot, may cut off blood supply to an area. So at the bottom of that paragraph it says, for example, arterial embolectomy may be necessary when blood clots form in the femoral, popliteal, or tibial artery. If a blood clot forms in a vein, medical treatment may be sufficient. With bed rest and administration of a thrombolytic agent, such a clot may dissolve. So what I need you to write under there is artery equals surgery. If there's a thrombus in an artery, it requires surgery. If a clot or a thrombus is in a vein, all you need is like medicine, some blood thinners. But if it's in like the femoral artery, the popliteal artery, or tibial artery, that equals surgery. Okay? All right. And so again, there are medical and surgical options to treat the condition of thrombosis. So let's talk about coagulants. Coagulants are drugs that promote, accelerate, or make possible blood coagulation. So that first one is hemostatics. Hemostatics are topical agents used almost exclusively in the surgical setting. Systemic coagulants are generally used in the medical setting. So that second sentence under hemostatics, these agents serve as adjuncts to natural coagulation, which controls minor capillary bleeding. Thus, traditional hemostatics are not effective against arterial or major venous bleeding. Hemostatic agents such as QuikClot have been developed to treat severe traumatic bleeding on the battlefield, in trauma situations by emergency responders, and by law enforcement. These agents are not intended for use in the routine surgical setting. So in the field, they're going to be using QuikClot to make sure that you're not going to bleed out. Hemostatics used in surgery are applied topically in the form of films, powders, sponges, or solutions. So let's talk about them. Okay, so again, the hemostatics are agents that enhance or accelerate blood clotting at a surgical site. Hemostatics serve as adjuncts to natural coagulation, and hemostatics are used in surgery and applied topically again in the form of films, powders, sponges, or solutions. You can see a beautiful table or a box on page 118, box 9.1, the topical hemostatics by category. And you can see here absorbable gelatin. I would underline absorbable gelatin. And look, there's gel film, there's gel foam powder, gel foam sponge, and then Surgifoam. So that's what we're talking about, the films, powders, sponge, or solutions. So films, powders, sponges. Okay. And then we're going to talk about the microfibrillar collagen hemostat, but I would underline that second one, Avitene microfibrillar collagen hemostat. I don't know if you've used Avitene. A lot of times you use that sometimes in neuro. And then there's oxidized cellulose. There's Surgicel, Surgicel Fibrillar, Surgicel New-Knit, and then SNOW, the surgical sutured nonwoven material. Okay, so these are all the topical, that means you're going to place it on the bleeder, topical hemostatics. Also at the top, there's that table 9.1, the blood coagulation factors. I would put a big old star next to that table. You need to know that there are 13 factors. You do not need to know all the names or functions, but I would know the pathways if it's extrinsic, intrinsic, or both. Okay. Okay, so the first one is absorbable gelatin. Under the coagulants, let's talk about the absorbable gelatin. So again, these are hemostatics. All right, so in the second column up at the top, gelatin hemostatics are absorbed completely in 4 to 6 weeks depending on such factors as the amount used and the surgical site. Gelatin hemostatics may be used dry or moistened with saline. However, they should not be used in the presence of infection and they should never be placed intravascularly. Examples of gelatin hemostatics include gel foam powder and sponges, Surgifoam, and gelatin spawn, excuse me. Okay, and then the last couple sentences before that little paragraph at the bottom. An example is gel foam used in otologic surgery such as tympanoplasty. It is cut into tiny pieces called pledgets, which may be used to pack the area around a tympanic graft or to apply a very small amount of epinephrine topically on bleeding surfaces inside the middle ear. And you can see what this looks like on page 119 in that figure 9.3. Okay. Okay, absorbable gelatin is a free agent of side effects, but it shouldn't be used when infection is present. So in the blue on 119, it says platelet aggregation. I just need you to know that that is clumping together. Platelet aggregation, clumping together. Okay. Okay, let's talk about absorbable collagen sponge. So collagen may reduce the bonding strength of methyl methacrylate, which is your bone cement, so it should not be applied to bone before placement of a prosthesis requiring cement fixation. Okay, so on 119 under microfibrillar collagen hemostat, Avitine microfibrillar collagen hemostat, or MCH, is a dry, fibrous preparation of purified bovine corium collagen. Direct application to bleeding surfaces attracts platelets to the substance, thus triggering further platelet aggregation, which is clumping, leading to formation of a fibrin clot. Avitine should be applied with dry instruments only because it will adhere to wet surfaces. Further down, in addition, contact with non-bleeding surfaces must be avoided because adhesions may result. So sometimes they'll put Avitine like on a freer and they'll use it as a spoon to spoon it into that wound and then kind of use it as also like something to tamp it down, to pack it down. Okay. So on page 120, that figure 9.4, that shows an Avitine microfibrillar collagen hemostat. And that's the various forms that you can see it in. A lot of times you'll see what looks like C, that flour, and so that's why I'm saying they'll put it like on a freer or on something that they could spoon it and then tamp it in. And again, you want to give it as a dry fibrous preparation because it attracts those platelets when applied and triggers platelet aggregation into thrombi. Okay, it has surgical application and again is applied topically only and with just dry instruments because it will adhere to the wet surfaces of any instrument that is wet or damp. Like absorbable gelatin, it's free of side effects. It's also contraindicated in the presence of infection, so do not use this in an infected area. Okay, oxidized cellulose. So at the bottom of 119, examples of ORC, which is oxidized regenerated cellulose, include Surgicel gauze, Surgicel new knit, which is a knitted fabric, Surgicel fibrillar, and Surgicel snow, which is that structured non-woven material, all available in multiple sizes. Surgicel absorbable hemostat is also bactericidal and effective against a wide range of gram-positive and gram-negative microorganisms. So this is just another type of a hemostatic in oxidized cellulose. Its action is not yet clearly understood, but when it's applied to bleeding surfaces, it swells and serves as a nucleus for clotting. So oxidized cellulose is used topically, often in neuro. While it's absorbable, it should be removed once hemostasis is achieved. This is something you do not want to leave in the body. Especially like if you have that new knit, if you've seen new knit, yeah, you take that out because that would be a retained foreign body. So like the hemostatics before it, oxidized cellulose lacks side effects. It also shouldn't be used when there's an infection. So a lot of these are very similar. Okay, thrombin. So the fourth line down, it is of bovine origin. Okay. Thrombin is a hemostatic agent of bovine origin. It works by converting fibrinogen to fibrin. And then table 9.4 on page 121 shows hemostatic agents containing topical thrombin. Okay, so I have underlined on there the thrombostatin under the brand name and Vitagel, which I'm sure you've heard of in GYN, Tacil and Evicel, those are pretty common, and then Flowseal and Surgiflow, those are very, very common. All of these I have heard of as a surge tech, so you will hear these also in your career. Um, that last sentence that goes into the second column on 120, thrombin should be used immediately after preparation, or it should be refrigerated and used immediately after reconstituting. And then where it says caution in that red and yellow box, I starred that. Thrombin must never be introduced into large blood vessels because significant intravascular clotting and death may result. In addition, to avoid an advertent injection, thrombin should never be kept on the sterile back table in a syringe. Okay, this is something that is given to you. You defrost it on your back table in a bowl in like warm saline, and then you put it in this special injector, and then you give it. So thrombin is used in general surgery, but topically only. It should be used immediately or again after reconstituting. And then when injected into large blood vessels, it can cause significant clotting or even death, which we just talked about. There are no side effects to speak of with this agent. It's important to note, however, that hypersensitivity is a contraindication. Okay, so here's a mechanical agent for a mechanical hemostatic agent, bone wax. So, second column all the way at the bottom, bone wax is used primarily in orthopedics and neurosurgery to control bleeding on bone surfaces. So that's next on the roster of hemostatics is the bone wax. It's made from beeswax and it's a mechanical barrier only. And you can see what this looks like on page 122. And you can see a lot of times you'll roll it into a little ball between your first and second fingers to get it kind of warm and pliable. And you'll put it on a freer and pass it like that. Other times, like that's for neuro. If you're working in ortho, you'll still like pinch off a little bit, roll it into a ball, and just give the surgeon the ball of wax. And he'll either apply it with his finger or maybe with like a Cobb elevator or something like that, or sometimes a freer. It just depends on where the bleeding is. So again, bone wax is used topically in orthopedics and neuro. It is a pliable, opaque, waxy substance that is sparingly applied directly onto bone, and it's lacking side effects, but it is contraindicated by hypersensitivity. All right, the type of hemostatic to discuss in the category known as chemical hemostatics is next. So what we just talked about prior are the mechanical, these are the chemical hemostatics. So some types of chemical hemostatics such as tannic acid or silver nitrate cauterize bleeding surfaces chemically. So we'll talk about some of these. Tannic acid may be used on other agents after tonsillectomy. Silver nitrate effectively removes granulation tissue or common warts. Tannic acid is a powder made from an astringent plant and applied with a tonsil sponge following tonsillectomy. And silver nitrate is mixed with potassium nitrite and molded into applicator sticks. Because silver nitrate has a caustic effect on mucous membranes, it should not be used in or around the eyes. So another chemical hemostatic agent is Monsil solution. And so it's a dark brown cauterization solution. We talked about it prior in a different chapter, but it's made of ferrous sulfate, sulfuric acid, and nitric acid diluted with water. And so Monsol solution may be applied to the bleeding surface that remains after cervical cone biopsy or like a leap or something like that. So it is very important to exercise care with this solution. Monsol solution is easily confused with another brown solution on the sterile back table, which is that Lugol solution. If Monsol and not Lugol is used to stain the cervix to reveal dysplasia for biopsy, the tissue in the biopsy area may be damaged. So make sure you know the difference between Monsol solution and Lugol solution. One's for cautery, one is to see dysplasia, cervical dysplasia. Okay, so systemic coagulants are the second main category of coagulant. So in short, systemic coagulants replace deficiencies in the natural clotting mechanism. The three types of systemic coagulants discussed here in this chapter are the calcium salts, vitamin K, and blood coagulation factors. So remember that calcium is crucial throughout the cascade. So as the body's most common mineral, calcium is crucial to many body functions, including blood coagulation. So calcium is administered before or during surgery by IV to restore levels and achieve coagulation. In the medical setting, calcium may be given orally or intramuscularly. So patients with malignant hyperthermia or MH should not be given calcium salts because that condition causes increased calcium release from muscle cells. Okay, so on page 123, under caution at the top, it says calcium salts are not given to patients with a history of malignant hyperthermia because one aspect of MH is increased calcium release from muscle cells. So make sure that you know that, just to reiterate. Okay, so under the vitamin K, that first paragraph towards the bottom, it says when surgery is needed urgently, vitamin K may be given intravenously, but there is an increased risk of anaphylaxis and it takes approximately 6 hours to produce an acceptable effect. So this is a Hail Mary here. And then at the bottom, vitamin K is available as phytonadione, no, phytonadione, excuse me, which is mephiton oral. Yes, and I heard of mephiton before. For oral administration or as phytonadione, yeah. Yes, that. Aquamaphyton, which is vitamin K for injection. I always stumble on all these medications. Anyways, so vitamin K is a fat-soluble vitamin that promotes blood clotting by increasing prothrombin synthesis in the liver. Decreased vitamin K levels are seen in patients on oral anticoagulants. So in the surgical setting, a vitamin K deficiency can lead to excessive bleeding, so it's important to replace that deficiency. And again, if needed, it can be administered by sub-Q injection 6 to 24 hours preoperatively because it takes that long to achieve that acceptable effect. So intravenously, vitamin K administration can, again, cause severe anaphylactic reactions, so it's rarely given by IV only when other routes aren't feasible. So the third and final systemic coagulant is blood coagulation factors. They are vital to the cascade, and a deficiency of any clotting factor interferes with effective coagulation. The two shown here are administered intravenously in the medical setting. And just to be clear, I want you to make sure that you understand what a systemic coagulant is. And you can read about it on 122, but it's the natural clotting mechanism. So the agents that replenish the deficiencies in the natural clotting mechanism. So these are things that we can give people that act more of how like the body would react to clotting. Okay, so preoperatively, coagulation factor 8 is administered to patients with hemophilia A, and factor 9 complex may be administered preoperatively to patients with hemophilia B. Okay, so there is a second main group of medications affecting coagulation. Anticoagulants are agents that prevent or interfere with coagulation. So before we're wanting to create that clot, now we're wanting to make sure the blood is not going to clot or overly clot. So the anticoagulants. I need you to write at the top of 123 next to anticoagulants that these are the most dominant naturally occurring mechanism in the blood. Anticoagulants are the most dominant naturally occurring mechanism in the blood. Okay. Halfway down that little paragraph, it says anticoagulants do not dissolve existing clots. Rather, they help to prevent new clots from forming. So this is a prophylaxis medication that we're giving, but if the patient already has clots, they will still have clots after administering anticoagulants. Parenteral anticoagulants are drugs administered intravenously, subcutaneously, or topically that interfere with blood clotting. So the third line under the parenteral anticoagulants, it says heparin sodium is the most common parenteral anticoagulant and it is used in both medical and surgical settings. Okay, so heparin sodium, or just heparin, is the most commonly used parenteral anticoagulant. Heparin works at several points in the clotting cascade by inhibiting factor 10 and inactivating thrombin, which prevents the conversion of fibrinogen to fibrin. So let's see, about a third of the way down on that first paragraph, it says heparin acts by binding to antithrombin 3, which is AT3, which is a protein, which greatly increases AT3's ability to inhibit the action of coagulation factors thrombin 10A and 9A. Binding with AT3 enables heparin to work at several points in the clotting cascade by inhibiting factor 10, interfering with the conversion of prothrombin to thrombin, and by inactivating thrombin, thus preventing conversion of fibrinogen to fibrin. Heparin also interferes with platelet aggregation and the formation of a stable fibrin clot. Okay, so heparin is the primary anticoagulant used intraoperatively. It's frequently used from the sterile back table during peripheral vascular procedures and is administered in a number of ways. So that second paragraph, it says heparin is measured in units rather than milligrams and is available in doses of 10 up to 40,000 units per milliliter for injection and in parenteral form only because it is poorly absorbed through the gastrointestinal tract. And then further down, onset of action is rapid, usually within 5 minutes with duration of 2 to 4 hours. So adverse reactions include increased risk of hemorrhage and thrombocytopenia or a decrease in platelets. So heparin use is contraindicated in patients with existing severe thrombocytopenia. So in figure 9.6 on page 125, you can see the heparin solutions, like all medications on your back table, they have to be labeled and their strengths clearly identified because heparin comes in different strengths. So it's possible to administer the same volume of heparin, yet give a dose far stronger than ordered. So please be careful. So again, although heparin was discussed earlier, it's important to reemphasize some important information about dosing from the sterile back table. So many dosing errors have occurred because 1 milliliter of heparin can contain significantly different units, from 10 units to 10,000 units. Use the general medication safety rules and exercise the utmost caution to verify the actual dose of heparin. So that last little paragraph on 124, it says heparin is also frequently used from the sterile back table during peripheral and cardiovascular procedures. A dilute solution such as 5,000 units of heparin in 1,000 milliliters of normal saline is commonly used in topical arterial irrigation. And next to that, you need to write an example would be like an AV fistula. So using that dosage of heparin, 5,000 to 1,000 milliliters, would be used on an AV fistula. Okay. Um, let's see. All right, so on page 125 in the second column, in the blue, the antagonist, which is the counteractive agent for heparin, is protamine sulfate, a parenteral anticoagulant that binds with and inactivates heparin. I drew a big arrow next to protamine sulfate, and I'm speaking from experience here. This will be on your CST exam. It was on both of mine that I took. Protamine sulfate counteracts heparin. Heparin counteracts protamine sulfate. Okay, these are polar opposites. Okay, at the bottom, if it is necessary to reverse heparin after cardiopulmonary bypass, 1 milligram of protamine may be administered for every 100 units of heparin that was given, depending on the time interval when heparin was administered. And then you need to know that note box. Protamine sulfate is also an anticoagulant when used alone. However, when given with heparin, protamine sulfate inhibits heparin's anticoagulant action. All right, so the low molecular weight heparins, or LMWHs, can be used outside the hospital setting because patients and their caregivers can be taught to administer the drug subcutaneously. Enoxaparin is used to prevent postoperative DVT following hip or knee replacement. It's administered by sub-Q injection, and it has a medical and not surgical application. Enoxaparin should not be given with other anticoagulants, including aspirin. Side effects include local irritation, pain at the injection site, fever, and nausea. All right, so the factor 10A is administered subcutaneously only. All right, so on page 126 under the oral anticoagulants, the second sentence, they are used for long-term medical management of thromboembolic disease such as DVT or PE. And the best one that's known, which are 2 lines down, is the warfarin sodium, or it's also called Coumadin. Okay, halfway down, the onset of action of warfarin is prolonged, usually more than 2 days, and its duration is 2.5 to 5 days after discontinuation. So this is a second category of anticoagulants, those oral anticoagulants. And again, they're used for long-term management of thromboembolic disease, including DVT or PE. So warfarin sodium, or Coumadin, a coumarin derivative, is a widely prescribed oral anticoagulant. Coumarin derivatives act by inhibiting vitamin K activity in the liver, thereby preventing formation of coagulation factors 2, 7, 9, and 10. So again, warfarin or Coumadin is successful in the long-term management of a number of conditions, and the onset of action of warfarin is prolonged, usually about 12 to 72 hours, and its duration is 2.5 to 5 days, but up to 7 days. Drug interactions are common with this agent, so all other medications must be closely monitored. Concurrent aspirin use is contraindicated. Common side effects include epistaxis, hematuria, and bleeding gums. All right, so aspirin prevents clot formation by inhibiting plate aggregation. So in the second column, that second paragraph, aspirin, also called acetylsalicylic acid, or ASA, is an antiplatelet drug that is considered an oral anticoagulant. It prevents clot formation by inhibiting platelet aggregation. So aspirin may be given after MI or recurrent TIAs to reduce the number of further incidents. Just 300 milligrams of aspirin can double normal bleeding time for up to 7 days. So remember, aspirin is contraindicated with concurrent Coumadin use. Okay, So table 9.6 on 126 lists generic and trade names for various thrombolytics. The third and final type of the anticoagulants are thrombolytics, and they help dissolve blood clots. So under that table 9.6, make sure that you know that streptokinase. That is that's a big thrombolytic. But about a third of the way down, it says thrombolytics are used to treat acute MI when coronary artery thrombosis is present. And so these are what you're going to be using to treat DVT and PE. And I wrote that in the column right there by the fold of the book, DVT and PE. So thrombolytics are used for DVT and PE. And then at the bottom, examples of first-generation thrombolytics include streptokinase, which is streptase, a protein synthesized by beta-hemolytic streptococci, and urokinase, which is albokinase and kinolytic, derived from human neonatal kidney cells grown in culture. All right, so alteplase or activase is a thrombolytic agent produced by recombinant DNA technology. It's a biosynthetic form of a naturally occurring enzyme, which is human TPA. And on page 127, where it says make it simple, that last part, I've starred that because thrombolytic medications often end with ACE. So it gives yourself a little easier way to study for these. Alteplase is used with heparin to treat acute MI. It may also help treat strokes, PE, and peripheral vascular occlusions. So because alteplase is a human enzyme, fewer allergic and hypersensitivity reactions occur. Another advantage is that it acts specifically targeting clots rather than exerting systemic effects. So now I want you to actually mosey on over to page 130 under the advanced practices for the surgical first assistant. We're going to go deeper into warfarin. So in that second column under long-term therapy, about halfway, it was talking about warfarin sodium, which is Coumadin. And about 2/3 of the way down, it says warfarin is an oral anticoagulant that suppresses the amount of vitamin K produced in the liver. Further down, warfarin's medication levels peak a few days after its administration, and it remains in the body for 2 to 5 days after it has been discontinued. So I'm just reiterating warfarin or Coumadin because this is a very, very common medication that a lot of people are on. And so they have to stop their Coumadin like a week to 10 days prior to surgery if it's a scheduled surgery. Now, if it's an emergency, then we just have to deal with it. And that's when we get our coagulants and all of our things that we're wanting to clot, like all of our medications and all of our things that we just talked about if they're on aspirin or Coumadin. And then on 131, that table 9.A, there it is again, that third down, the warfarin sodium is given PO. Okay, so by mouth, PO, that's the route. The indication, it's a long-term prophylaxis for thromboembolism. And then there's the dosage, 5 to 10 milligrams per day for 2 to 5 days. Then 2 to 10 milligrams every day as maintenance or dependent on the INR results. Okay, and that's all I need you to know in this area. So if you have any questions, please bring them to class.